So today we are delighted to be joined by our colleagues from Christian Social Services Commission. We have 3 panelists who will share with us their experience, their vast experiences and engagement in the FBO facility, in the FBO sector, in supporting the health system strengthening in the country. So we have Dr. Godfrey Kwai, who is just, maybe can you raise your hand, Dr. Kwai? Dr. Kwai is working with Christian Social Services Commission as the project manager for the PACTA activity. This is the project that aims to enhance sustainability of the health of the FBO facilities in the country. Dr. Kwai is a public health specialist with extensive experience in health system strengthening, and has also been working in the private sector for a couple of years now, especially those which are being supported by the USA donor funding. So we expect Dr. Kwai to share with us insights on how the FBO sector has been engaging itself to support the government in the areas of health financing, to ensure that the population in the country, especially those people who are residing in the rural areas, are accessing services in the localities. We also have Dr. David Isaiah, who is sitting at the far left. Dr. Isaiah, can you raise your hand? Dr. Isaiah is an experienced quality assurance coordinator with over 8 years experience working with both public and the private sector. So we expect Dr. Isaiah also to share with us his experience in health system strengthening, especially in the area of reproductive, maternal, and newborn health. Also, you have Dr. Goodluck Mwakitosha, who is sitting at the middle. Dr. Mwakitosha is currently working as the technical advisor for CSSC. He has an impressive academic background with passion for healthcare improvement and is a trained medical doctor also. He has also served in both public and private sector. So, as I mentioned, most of these facilities that are coordinated by the network by the Christian Social Services Commission, most of them are located in the rural areas, 40% of them. So we expect now to get some more insight from the panelists on how the faith-based organizations has played a big role and its contribution in strengthening the healthcare system in Tanzania, focusing on how the integrated healthcare services and the impact of the partnership that we have in the country can lead to that outcome in the delivery of health services. So to start with, I'll take this through I'll lead through the team through a number of questions. Then we have time to discuss as a plenary. So to start, maybe I should start with Dr. Goodluck Mwakitosha on the area of governance. So Dr. Goodluck, can you share with us your experience in terms of how leadership and accountability in the health facility plays a great role in enhancing the provision of quality healthcare services in the country?
Okay, thank you very much. As we heard from the introduction, FBO facilities, which are coordinated by Christian Social Services Commission, most of them are located in the rural areas. CSSC has been on the front line to ensure that these facilities deliver quality health services, but maintain its relevance in terms of providing services to the poor. So as CSSC, we have been working to ensure that leadership and accountability in these facilities is strong enough, starting from the boards or facility governing committees, to ensure that they are functional, they are able to lead, to govern the facilities in terms of making sure that they implement their strategies. So strategically, we make sure that the facilities have strategic plans, they have workable plans in terms of activities which they're supposed to implement. Therefore, we make sure that the boards are able to supervise the facilities. In this, over the past 5 years, CSSC has been striving to ensure that the boards have members with diverse skills, mixed skills, having members with various qualifications such as human resource and administration capacity, members with the health service delivery capacity, but also members with financial and auditing capacity. So in this, in 2021, CSSC conducted an assessment to see if these boards or facility governing committees are relevant to supervise the facilities. One of the findings which came out was that most of the boards or facility governing committees were available. However, their composition, the members had no adequate mixed skills to oversee the implementation of activities in facilities. Even the issues to ensure that the facilities have strategies or work plans and budgets, as well as the management of revenue and expenditure. So CSSC, as an organ for these facilities, developed customized the generic facility governing committee or board guideline that stipulates clear roles of the boards, and including the separation of power or separation of roles between the owners of the facilities as well as the roles of the board or the chair of the board. Previously, most of the facilities have been led by the owners. If it is a bishop or is the head of congregations, sometimes they become the chair of the boards or the facility governing committee, so the roles becomes difficult to be taken up. So from this guideline, CSSC managed to work with the owners of the health facilities, including the health management teams, to restructure the existing governance or the existing facility governing committees, to have members with mixed skills, to have members who knows their roles, as well as the separation of power or roles between the owner and the board. So owners agreed to select some chairs and members out of the facilities, out of the dioceses or congregations who are able to supervise the facilities, and also guided the facilities to develop strategic plans, develop the tools to ensure that the boards are able to evaluate the performance of the facilities. Also, the owners of the facility have capacity to evaluate the functionality of the board, the roles of the board, to ensure that the board is able to strategically monitor the progress of implementation of the facility, of the performance, in terms of revenue, in terms of technical, but in terms of quality. Therefore, currently, 16 out of 22 health facilities which were identified to have inadequate functional board have adopted the developed guideline. They have revised the members. They have guided the facilities to develop strategic plans, as well as the workable budgets and the annual work plans. And in this, even the separation of roles between the facilities and the owners has been very clear in terms of supervision as well as service delivery. So in this, we understand that we have many facilities, but it has been difficult to tell the owner that he or she should not become the chair of the board of his own facility. But this has been taken up slowly, and as they see changes in the facility which started implementing these changes, other facilities have also been adopting this model, and it's going on very well. Thank you.
For the interest of time, I'll request the panelists not to spend more than 2 minutes in each question, so that maybe the plenary could have time also to contribute. So the second question goes to Dr. Isaiah. So for quite some time now, FBO health facilities have been praised for offering quality services in the country. What is your opinion with regard to this statement? 2 minutes in each question.
Thank you. It's true. As we know that most of these hospitals were founded before we got our independence, and we have some examples of hospitals like Peramiho, which was founded in 1880s. I think it's more than 130 years ago, and it's still existing. But these hospitals, when we were founded, were heavily subsidized by assistance from donors. These were churches from Europe, and also some governments also assisted these hospitals. So, and also they had some experts from these countries who came in to work together with the local experts. So having these mixed skills also raised the bar of quality for these hospitals for quite some time. And also faith-based facilities have been pioneers of different quality initiatives in the country for a long time. And a lot has changed recently. As we know, some donor fatigue, but also the issue of competition from both public and private hospitals, but also there have been decreased funds also from public, as we know. This has challenged the quality of service, but still, in most places, especially the rural areas, these are facilities of choice for most of people. They don't have alternatives, so they are still the best in terms of quality as if we assess in general. Thank you.
Thank you, Dr. David. So the third question goes to Dr. Godfrey. Will you agree with me, financing is an important aspect to ensure that health facilities provide quality services? How is the CSSC supporting hospitals to have innovative and sustainable financing options in the country?
Okay, thank you. You all agree with me that financing is the most challenging part in the health sector, not only in the country, but even in other countries. So specifically for the faith-based hospitals, as Dr. David had enlightened later, our facilities were started as missionary hospitals, so they are almost 100% dependent on donors for their investment, but also the operating costs. But you know, over the years since 1992, things started changing, and there was significant decrease of donor funding. But then during that time, we entered agreement with the government, and we started receiving a lot of grants from the government. But also in the recent years, there's also been a declining funding from the government as well. So at CSSC, as a coordinating body for the faith-based hospitals, we started supporting the facilities to reduce dependence. This in two ways. First, to generate more, and this is to become more innovative, in order to attract more clients who could afford to pay for services without neglecting those who cannot pay for services though. But another one is to reduce the operating costs. So when we started supporting these facilities, our internal contribution in the overall budget was around 43%, but now we are around more than 54% contribution of the overall operating budget coming from the internal funding. So for us, this is a significant achievement, and we have done some analysis, and we think that once we reach at least 60% contribution of the patient fees to the overall budget, then at least these facilities can be sustainable. As you all know, at least 40% of the PEPFAR-supported sites, for example, are faith-based, and therefore but the PEPFAR has done a lot of investment in the primary health sector, especially in HIV and TB. So sustainability of these facilities is really critical because it also means sustaining PEPFAR efforts and other development partners who have really invested for many years in health sector. Thank you.
Thank you, Dr. Godfrey. So I'm suggesting for the interest of time, we just take note of the question. If you have questions, we'll have time to ask when we finish this session. So please take note of those questions. We'll have time to ask at the end of this presentation. So the second round of questions goes to Dr. Goodluck Motosha. As I mentioned in my opening remarks, that the availability of competent human resource for health, especially in the private sector, including FBO facilities, is a growing challenge. How is CSSC working to address this challenge to ensure there is a continuation of the provision of quality healthcare services in the country?
Yeah. CSSC. Okay, CSSC contributes to the availability of human resources in the country because we coordinate about 65 health training institutions, which produces about 2,500 middle cadre healthcare workers who are mostly needed in the rural areas. Apart from that, we understand that the facilities have shortage of staff. However, the existing staff are not fully utilized sometimes. So we have developed a program, staff development program, which includes performance management, and we also adopted the Macaulay model approach of making sure that the individual performance of staff is well monitored at the facility level, but also building capacity in terms of accountability of managers at the health facilities to be able to supervise the staff to ensure that we optimize their performance and in the delivery of health services. We also do some kind of building capacity of the staff through mentorship on job training, as well as the clinical attachment of staff from the lower level facilities to the higher level facilities to ensure that they improve their competence in terms of providing and improving newborn and mother's outcome. Thank you.
Thank you, Dr. Goodluck. So the second question goes to Dr. Isaiah. We all agree that quality is very key. So maybe Dr. David, will you please share with us what have you been doing as the quality unit for FBO facility to improve the quality of care in the healthcare system?
Thank you. FBOs plays a very important role in addressing quality of services in the country. And in 2002, maybe I can start with recent information. We developed the standards for church health facilities and also the indicators for quality and the user guide of care workers. If I can recall, this could be the first standards of quality in the country because we had never had these standards until 2014 when the safe care standards for primary health services were established by the government. So these of the FBOs were the first standards that we were using, and we had a user guide that one could go and assess the level of quality in a health facility by having a set of indicators that could be measured. And when the safe care standards were established in 2014, we were the first to adopt the standards, and the 250 health facilities were enrolled in this, and out of which we got 3 which reached the level 5 of safe care, and 24 were in level 4, and the rest were in level 3 and 1. But also we are part of the team that, together with Pharmaxis International and the government, pioneered the first standards of quality for regional and zonal referral hospitals in the country, and we are the one who are still using them right now. I think the government started using them for 1 year, and then we continue to use them up to now, and we have facilities that are being assessed using those standards. But also we are part of the team that pushes for the accreditation body in this country. As a country, we need to have an accreditation body so that facilities that perform better can be accredited, but also that could be the source for insurance companies to reimburse facilities based on quality. That's what we are doing so far.
Thank you, Dr. Isaiah. Dr. Kwa, you mentioned that the majority of the FBO facilities are located in the rural areas where majority of the poor reside. So what do you do to ensure that the poor still have the access to quality healthcare services?
Okay, thank you. Yes, so it's true that at least 60 to 70% of our facilities are located in the rural, and we are the leading providers of specialized services in the rural areas, but these services are also expensive. So what we are doing is we have done market segmentation in the facilities to kind of create different products that would attract for the corporate insured clients or those clients who can pay more for services, so that we can also subsidize for the poor. So the poor are really subsidized, and there are mechanisms in the facilities to identify those who cannot afford services so that they can also get the services. But then in terms of the community, because this one is really draining the hospital resources with big numbers of exempted clients. So what we are doing right now is we are mobilizing the community through the faith leaders to kind of sensitize them to be enrolled on health insurance. But there are some communities that can also not afford the health insurance premium. So this one, the challenging part is to really identify those who are really poor so that they can be supported. But in a small scale, we have started to support the vulnerable children and the poor families to get health insurance, the national health insurance, through the contribution from the churches. For instance, in Arusha, DC, we have already enrolled 45 children who are HIV infected, and their families have been enrolled on the health insurance so that they can access services using their health insurance for those services that will need paying. Another modality that we are working on is to now have a sustainable trust funds within the dioceses and the communities to be supporting the poor families, but in the same time advocating for others to enroll on health insurance. The challenge that we still have is that there is still low risk perception, especially among the producers, the bread earners, on enrolling on health insurance because they don't get sick more often. Only the vulnerable at the extreme, the old and the children that get sick more often. So the energetic people who are working they are still have low risk perception. So I think we still have to work with other partners, especially the government and other stakeholders, to see on how Tanzanians can be sensitized on the importance of having health insurance.
Thank you. Dr. Goodluck, in 1 minute, what do you consider to be the main challenge as far as the issue of governance and HRH is concerned, and how are you addressing that?
One of the main challenges is the mindset change from the owners of the facilities, from the management of the facility, in terms of shifting into more accountable way, making the facilities being accountable to the board, and the board become accountable to the owners. Though after seeing the results, the changes goes gradually.
Thank you. Dr. Isaiah, throughout your interventions, what do you consider that has worked very well and what does not work? And how have you been what had been the main challenge so far?
Yeah, in quality, in health facilities, for a facility to improve quality, whether be it private or public, the first thing they should have a program, a quality improvement program that they are implementing. Quality cannot just drop from the air. They have to plan to have a program that they follow. And also what we have seen working very well is if a facility designates a person who is in charge of quality, and this person should be excluded from other duties in the hospital. For those facilities which have done so, we have seen them improving in a lot of areas, including even in the revenues, apart from improving other areas in quality. But also, the management should take quality serious. Quality improvement coordinator or chairperson should be part of the management, and quality should be among the first substantial agenda in every management meeting. You cannot escape that if you want quality to improve. But also we've seen a lot of things that are working in quality. We started implementing clinical audits in all FBO health hospitals. Currently, we have reached up 22 hospitals. Those facilities which are taking clinical audits serious are improving tremendously. You can see if they're scoring very well in maternal care, in finances, in all other areas because they're doing well in clinical audit. So far, that's what I can recall.
Thank you. My last question goes to Dr. Godfrey Kwai. So, Dr. Kwai, supply chain is one of the major cost drivers in the health facilities. How do you ensure that the facilities have access to affordable medicines?
Okay. Our facilities also get medicine through MSD, but they get around 50% to 6% of the requirements. So there is a 40% unmet gap, and this makes them to very private companies to procure medicines, but also because they do not have enough funds, they procure quantities, which becomes very expensive for them, and this goes as a burden to a client. So what CSSC is doing is to establish a supply chain company that will complement MSD efforts so that we can avail affordable and quality medicines to the facilities so that we can reduce the burden to the facilities. But also because these facilities, we have a network of facilities and small facilities that cannot afford to buy medicine in bulky. So we are joining them, and we will be doing pool procurement for the facilities so that they will be doing periodically, not on a regular basis, and therefore they can get medicines at an affordable cost. And this will have impact also on the end user because the end user can also get affordable medicines. But as CSSC, we have the role of mobilizing resources. We are discussing with several partners, and we have some potential partners who might be providing for us some donated medicines that we can give to the facilities, and therefore they'll be giving to clients who cannot really afford the cost of medicines. And this does not become a burden to the facility. Thank you.
Thank you, panelists, for sharing with us your insights and experiences on the role of the FBOs in the delivery of healthcare services in the country. So we agree with me that we have a very thoughtful experiences from the team. Maybe join me now to give them a round of applause. It's now your turn now. If you have questions, maybe you can ask to either of these colleagues in front. Maybe I request it to be so brief so that maybe you can have more time to ask more questions. Maybe we take three, then they respond.
Thank you very much. So I'll just go quickly to ask. My name is Isaac Lema. I'm from Muimbili. So as a mental health expert, I was asking if there is any kind of a plan of improving our rehab. I know Lutindi has been there for quite some time, and we are looking really ahead to improve mental health services in our country. As we are now talking about having mental health services in KSMC, Bugando, and other hospitals. What about Lutindi? Thank you.
Thank you. A second question?
Thank you. Mine goes to Dr. Kwai. In terms of health financing, what are the steps taken for sustainability and self-reliance once the donor programs ends?
Thank you. The third one.
Thank you for this presentation. I'm John from UNICEF. I'm wondering if you can help us to understand how you how you manage with the children, mothers, and the elderlies who are subsidized or who are not expected to pay while you are getting funds from the churches or whatever if you are supporting.
Thank you. Maybe Dr. Kwa, you can start. The issue of the children, mothers who cannot afford to pay, and also the issue of health financing, self-reliance for the FBO facilities.
Okay, so first of all, our facilities are receiving funds from the government, and there are some council-designated hospitals in VAH. So there is agreement with the respective councils on how we manage, based on the government policy, to attend the pregnant mothers and children under 5 who cannot afford to pay the services. But as I highlighted earlier, in some cases, exempted clients can be more than what the government is supporting the faith base. And that's why we have created now a market segment to kind of provide additional services to allow those who have ability to pay more for services, or those who have corporate health insurance to pay more, so that we can subsidize those ones. But again, we have another mechanism of identifying those really poor and support them to enroll into health insurance through the churches. As the example I gave from Arusha DC, where we have started a pilot, we have now insured 45 children and their families so that they can access services from the health facilities, not only from the faith-based facilities. But the challenging part, I said, is still the mechanism on how to identify the poor, those who really need the support, because as you know, some of the Tanzanians feel proud to be called poor, so it's really difficult to tell like who really actually need the support. But with regard to the steps of sustainability, this is what I say, that we are trying first to support facilities, improve on the efficiency so that they can really minimize the operating costs, and also taking digital solutions and everything, but also supporting them to generate more. At the moment, we are at 53% funding our own operational budget. So our target is to go to at least 70%. If we can reach that, that's our dream. And we think by then, even with the absence of donor funding, because now even the donor funding at the moment is 8%, the rest is from the government and internally generated funds. So we think we can be sustainable in the future, even in the absence. Sorry, I also respond to the Lutindi question as well. This is one of the things that we are saying, that we are doing segmentation. At the moment, Lutindi is only offering mental health services, and majority of those cannot pay. So even the money they pay there is very little. And the hospital also has an agreement with the council, but we receive clients from different parts of Tanzania. So we are also in discussion with PRH and Ministry of Health to see on how they can support the hospital, because that hospital does not only attend the mental cases from the Lutindi area only, but again, we are trying to see on how on themselves they can come up with additional services that will attract paying clients, so that even we can sustain the mental health operations there. Maybe my colleagues, if they can add anything.
Dr. Isai? Okay. Maybe can we take 2 more, if you think? Yes.
I think I can be loud. Good morning. My question is, what role do you think
second question? Are we all okay?
Good morning, Elise Lang from USAID. You spoke about the mind shift changing as being one of the most challenging aspects towards improving hospital quality and sustainability. How do you think that can best be scaled, or what are some strategies you think to continue to shift those mindsets?
So who will respond the first question on the prevention? Why are we not investing more on prevention than on curative services? Dr. Good luck.
Okay, thank you. CSSC has a main objective of non-communicable diseases as well as other diseases prevention. So we have a program of screening the risky behaviors at the facilities, but we had a know your number, some kind of a slogan which also promotes communities to go for screening and understand their risks of acquiring non-communicable diseases. Thank you.
Yeah, maybe I'll add on the prevention. As you know, faith leaders are very trusted in the communities, and we work very close with the faith leaders. So with regard with diseases like HIV and we're now engaged, empowered the faith leaders to talk about HIV through the messages of hope that were developed and other educating messages. So now they go to the communities to advocate for, especially among the youth and the young age population, about the risky behaviors, you see, and things of the sort, so that they can minimize chances of getting HIV infection and the rest. So with regard to Alice's question on sustaining the mindset change, right? So when we were starting, for example, our partner activity that is USAID funded, most of the faith leaders had given up in investing further on health sector because it was becoming too challenging. The managers will go to their doors to ask for salaries for staff and things like that. But when we were starting the project, we showed them, we wanted to demonstrate a case that it is possible for the hospitals to generate adequate funds without being a burden to the diocese. But first, improving the governance itself, it will have a bigger impact. And I think by now we have shown the case, and more faith leaders are now more willing to kind of shift into that area, having more corporate governing boards that will oversee the hospital in terms of also support the diocese in resource mobilization, ensuring accountability. And this will no longer be the burden of the faith leaders or the owners. And therefore they've seen that it's possible, because initially it was. So by sharing the best practices, because we have platforms that bring them together every year at least twice, by sharing the best practices and showing what we have achieved by changing the governance structures, then this one will motivate more owners and faith leaders to adopt these new governance systems and stuff. Thank you.
So thank you, Dr. Kwai, and the panelists, Dr. Goodluck and Dr. David. So you all agree with me that the role of FBOs in the health sector cannot be underestimated. We have heard from the team that almost 13% of the CSSC network, of all the CSSC facilities, almost 40% of them are located in the rural areas. And from the statistics that we have in the country now, it's like 13% of all health facilities in the country. They are coordinated by the FBO network. So agree with me that we have the big role to play in terms of improving the healthcare services in the country. So for these closing remarks, we thank you for joining us to further discuss this. And we thank also the panelists for sharing with us the experience and the expertise and the role of the FBOs in the delivery of health services in the country. Thank you all for joining us.